to our welcome to our second clinical basic science meeting for today. So today's meeting is hosted by both CRU and CRCD. So today we'll start off with a case of a chronic cough. I will present the case and we'll discuss with Prof. Ng on the clinical aspect. Following that, Prof. Nya will just discuss with us on the basic science aspect of the case. So without further ado, I'll just start the ball rolling. So this is a case of a chronic cough. So I was referred a patient, okay, a 23 years old Indonesian male who has been coughing for the past 2 months. He has completed 1 course of oral antibiotics, but is still not improving. So the GP referred this patient to me for further management. So before we start, I will just ask, how should I approach this case? So I'd like to invite Prof. Ng to just briefly tell us how would you approach a case of chronic cough?
Yeah, thank you, Kang, for the invitation. Let me share some introductions in terms of the chronic cough, and followed by the approach in terms of history and examinations. To begin with, chronic cough is actually one of the most common complaints in our routine outpatient practice. I believe for those who are practicing out there, you do see them in many occasions during your outpatient clinics consultations. And cough can be classified into 3 broad categories. It all depends on the duration of the cough. And number 1 is acute cough, which is actually the cough with a duration of less than 3 weeks. And usually it's due to upper respiratory tract or lower respiratory infection. Sometimes it could be due to acute exacerbations of underlying lung diseases like the asthma, COPD, or even the acute exacerbations of the underlying interstitial lung disease, right? Which we do see them as a respiratory physician when they get referred to us. And subacute cough is defined as a cough with a duration of 3 to 8 weeks, and chronic cough with a cough of duration of more than 8 weeks, which is actually occur in this particular patient. Next slide. And I just outlined here the causes of chronic cough is largely divided into common, which constitute up to even 95% of the cases, or less common causes. These are outlined here. For common causes of chronic cough, these are the 4 important common causes, such as upper airway cough syndrome, and some are also known as post-nasal drip syndrome, right? Asthma, gastroesophageal reflux, and post-infectious causes. And most of the time when you see the patient with chronic cough without apparent abnormal examinations and X-ray, these are the 4 common causes you are dealing with, right? And on the right panel here is the less common causes. Example, airway related. These are example, eosinophilic, sorry, there's some background noises. Some people mic is not muted, right? There are airway related example, eosinophilic bronchitis, chronic bronchitis like in smokers, bronchiectasis, lung cancer, foreign body, or even on ACE inhibitors. For those with parenchymal lung diseases like interstitial lung disease, lung abscess, chronic lung infection like TB, or left ventricular failure. All right, move on. What the evidence says about chronic cough, right? So these are some important, some interesting facts, right, to share with you all. A cause is identified in 75 to 90% of patients with chronic cough. And as much as about 12% of are being idiopathic, no matter how extensive you have searched for the causes, it's being idiopathic in nature. And usually these are the causes linked to what they call the heightened cough reflexes that leading to cough, and you tend to resolve perhaps after 2 or 3 months. Despite all the investigation, you can't find the cause, right? And 27% of the cases that you see in the clinic had more than 1 cause. Meaning to say the patient could have post-nasal drip, and it can be exacerbated by the GERD, for instance, or patient with asthma can be exacerbated by the GERD, for example, right? Or simply a patient with the lung TB may have underlying chronic sinusitis with post-nasal drip syndrome. So there are combination of causes that leading to the cough as one of the presentation of the chronic cough, right? And number 4 is for those common causes that I outlined earlier, upper airway cough syndrome, asthma, GERD, either they happen alone or in combination, accounted for 90% of cases of chronic cough, right? Of the above causes, 99% of the patient, they have the following characteristic, such as non-smoker, no use of ACE inhibitors, normal, near normal, or stable plain X-ray. If when you assess a patient with this characteristic, they're likely to have the above causes most of the time, all right? So now, importantly, when you approach a cough, chronic cough, you want to try to find out the exact cause and give a correct treatment, right? To cure the cough. So history, examination are important, and you try to find the reason for the cough. And these are the compilations of some history information that I think, as a respiratory perspective, which we have, always see the chronic cough patient. These are the important history one should actually look into, which will help you to get the certain diagnosis, right, based on the history. If the patient having nocturnal cough, it could be due to post-nasal dripping, and more so if the patient have history of allergic rhinitis or sinusitis, or it could be simply GERD that occur actually at night, and while lying positions, they have nocturnal cough, which get worse at night, maybe while sleeping. And more so if they have concomitant heartburn after meal or sitting or bending over, right? And though it's asthma, their cough may get worse in the early morning or at night in the cold weather. And more so if they have atopic history, they have wheezes and a strong family history, right? Those patients with chronic cough with significant amount of sputum, think of infections or even bronchiectasis. And those fever, do not ignore them. It could be infections, especially TB, all right? Or lung abscesses, or even those with parapneumonic effusion, which is not resolved after seeing a GP for a few times with antibiotics. So don't ignore those patients with fever. And it could be simply a malignant fever with a low-grade fever, tingling, but usually they have other associated symptoms as well, right? And again, hemoptysis. I always say this is a warning features, right? As someone with cough with hemoptysis, there must be something going on wrong in the lung, right? So example, lung cancer, infection, even acute infective exacerbation of bronchiectasis. Someone with short of breath, it could be due to obstructive airway disease, like asthma, COPD, or underlying interstitial lung disease, or even cancer, all right? And weight loss, don't ignore them. TB, cancer is one of the common cause of chronic cough with weight loss. And those on ACE inhibitors, especially they have tinkling, scratchy, and itchy sensation of the throat. That could be due to ACE inhibitors if there's no other explanation in your history and examination, right? Smoking history is very important. It is a risk factor for COPD and also can exacerbate asthma. And also there's an entity called smoking-related bronchiolitis, which is a form of interstitial lung disease as well, right? And occupational history actually very important. You may be dealing with someone with cough variant asthma related to occupations, right? So these are the important history that you like to pay attention into, right? Next one, physical examination. You try to look for the sign when you examine the patient after the history. You look for the sign of underlying lung disease or other medical condition. Give you a clue that maybe some cause reviewed by your examination. If you were to see a patient very thin and cacaxed, emaciated, I always tell the medical student, TB or my medical officer, TB or lung cancer until proven otherwise, right? And simply take out a hand and look at the finger clubbings. And if the patient also cause crepitation, a lot of sputum production over the months, think of bronchiectasis, right? And don't forget, look at the nose for enlarged or inflamed turbinates, right? Or coupled with the history of allergy and all that, you may be dealing with post-nasal drip. Or those, look at the throat, at the posterior pharynx, the cobblestone appearance, right? A cobblestone appearance on the posterior pharynx, and or tender sinuses, coupled with the history of sinusitis, that can point toward post-nasal drips, especially there's no lymph node, the lung was clear and no other sinister or warning features from the history, right? Next, and lymph nodes. And I give a lot of information, especially you're dealing with cancer, TB, or lymphoma, for example. When I examine the nodes, I've seen a foreigner having intermittent cough for 6 months, a little bit of weight loss, not so much, and has been walking around and still working and healthy in a way. And not short of breath, and fever is kind of like negligible, and present with a huge mass with this kind of appearance, even worse than this, right? When you feel it, it tends to be matted, and there's a sinus discharges, and that particular patient actually be chalky whitish material discharge, which is a cacheating material, right? Discharge from that particular mass is actually a matted lymph node indicating of TB. And we did a biopsy, FNAC, and sent for culture and proven to be TB, right? Or you simply feel the lymph node of the supraclavicular region or anterior cervical lymph nodes is hard and could be solitary in nature, coupled with chronic cough with weight loss, example. It could indicate underlying lung cancer with localized or distant lymph node metastasis, right? And simply look at the neck with multiple enlarged lymph nodes, sometimes, classical description of bull neck, and we feel it is multiple and rubbery in nature. And the patient may have chronic cough, maybe due to pure effusion that presented with chronic cough, example. You may be dealing with some form of Hodgkin lymphoma, right? And simply listen to the lung for wheezes. If you hear a generalized wheeze, you may be dealing with asthma, cardiac asthma, or COPD. When there's a localized wheeze, you may be dealing with endobronchial obstruction. Meaning to say, when you listen to the right lower zone, example, there's a right lower lobes bronchus partial obstruction. That will give rise to wheezing sound, but it's only confined to that particular region. The rest are pretty clear. And you're not dealing with asthma, but that is actually some for endobronchial obstructions, right? We have seen it ourselves during the ward round when we're dealing with the lung cancer. All right, move on. Yeah, I think there's an overview of the causes and the approach in terms of history examinations, right? Now back to you, Kang.
So from the history, so this is actually a 24-year-old Indonesian male. He's from Pontianak. He came here actually on a social visa, but was illegally working for his relatives for the past 4 months. So the history was he has been coughing for the past 2 months with a greenish phlegm initially and sometimes intermittent fever, but the fever was negligible, does not really disturb him a lot. So 1 month ago, he has seen a GP, was given 1 course of antibiotics. He couldn't remember the name, but after finishing 1 week, the cough was still there. He noted that there's some blood in the sputum. He has lost 10 kilos in the past 1 year, and it was unintentional. No shortness of breath, no chest pain, no hematemesis, no melena or other bleeding tendencies, and he denies any TB contact. So he doesn't know anyone who has TB. So for the questioning, there was no wheezing. The cough is the same day or night, not worse with exertion, no other ENT complaints, no GERD or indigestion symptoms. The house is a bit dusty, but there was no pets. No smokers around him, no curtains or carpets at the home as well. He has never been hospitalized before, no non-medical illness, no surgery before, no allergy history, no TCM medications or over-the-counter meds, no known diseases in the family, social history, married for 3 years, no child yet, non-smoker, occasional drinks, no drug use. The wife and the sister-in-law and him currently work together and they stay together in a house, but denies any sick contact. So nothing simply in diet as well. So after that, I move on to the examination. He was a bit thin for his height and of 175, the weight is 44. So the BMI should be somewhere about underweight. The BP was still okay, 103/72 for someone who's very thin. The heart rate was a bit tachycardic, but the rhythm was regular and the volume was normal. SpO2 was 98% of the room air, mildly cachectic looking, and there were no cervical lymph nodes felt. No features suggestive of immunocompromised state. There was no whitish seen on the tongue or anything, no lymph nodes. He was quite well, actually, like a bit thin. So for the heart, there was no murmur heard. Heart sounds were normal. And on examining the lung, there was a bit of reduced air entry over the left lower zone, which was normal on percussion. Abdomen was soft, non-tender. Everything else was normal. Neurology and musculoskeletal examination was normal as well. So on here, I was just thinking, how would you want to investigate this patient? So before we move on, I would just like to ask our audience to have just a brief poll. How would you want to further investigate this patient based on the history? What other routine do you want to do? So is it just to do an X-ray, or you want to send for sputum for acid-fast bacilli? You can go straight to a CT thorax, or you want to do a lung function to test the function. So I'll give you all around 20 seconds for you all to vote. What would you want to do? This is a young man from Indonesia, quite well, no TB contact, cough for 2 months, a bit of blood streaked sputum. Okay, I'll give it more 10 seconds. We'll close at 55 seconds. Three, two, one. Okay, I'll just end the poll. Okay, let me just share the results. So 72% of you wanted to do a sputum for acid fast bacilli. 13% think it's just enough. Let's stop at the X-ray and see how. 10%, 11% wants to do a lung function test to test its function. There's no shortness of breath, so I do not think that a lung function test was actually necessary. And 3 of you want to go for a CT thorax straight, which is okay, but then again, it's a bit overkill for this patient. It could be a bit costly, and there's no need for excessive radiation at this moment. Okay, so just proceed with the case. So how did I investigate this patient? So before I go on, I'll just ask Prof. Ng, in this kind of patients, how do you usually investigate these patients, Prof?
Hi, Kang. Yeah, thanks. Okay, before I go on with the slide, okay, based on the history assessment, very clearly stated that these young men actually present with chronic cough, which are also associated with some very significant symptoms, which suggest underlying lung disease and which warrant further investigations. And those so-called common causes that I've highlighted before, like GERD, post-nasal drips, and asthma, or even post-infections, those common causes are not apparent in the history, and which the history also rule out to some extent. In view of the fever, weight loss, right, and a significant amount of sputum, which is also greenish in nature, tend to suggest infections. So therefore, this patient will warrant further investigation. So now for those with chronic cough with such what they call the clinical history, X-ray will be warranted, right? Because it doesn't fall into the group of having so-called the common causes, right? So therefore, X-ray is warranted. And many times, these are the other investigation I highlighted here, depend on the clinical ground, right? As what Kang has put up, Dr. Kang has put up those so-called single answer options, but you are not confining to just that one answers, right? It all depends on the clinical assessment. You may need images, blood investigations, or microbiological investigation, depend on your clinical suspicious and clinical diagnosis, right? And what Kang was mentioning, which is quite right, when some of you actually want to order CT scan, it's kind of like overkilling. But in my personal opinions, it all depends. Sometimes it's no longer kind of like evidence-based so much, but it's more on personal preferences. So my take will be whether you are working in private or in a government setup, right? So many times I used to work in private for about 7 years. Private practice, it tends to be more what they call the defensive in nature. And at times, we may tend to actually overkill in certain aspect into investigation, for example, right? Put it aside. So back to normal and back to basic. So in this case, X-ray alone may not be adequate because history-wise, I think all of you get the right answers of wanting to do a sputum acid fast bacilli harassment, because in your mind, it's very clearly illustrated in the history that the patient is having a likely diagnosis of pulmonary tuberculosis, right? But not forgetting, do you all think that this patient is still possibly having cancer at the age of 23, right, Kang? Yeah, 23. Anybody can answer that? Do you think differential diagnosis will be cancer of the lung? Anybody? The answer is yes or no, right? But looking at the history, there's no smokers. Many of the lung cancer, adenocarcinoma, they are not associated with smoking, all right? But by and large, those lung cancer patients, 90% are That's why with smoking. But there are some proportion of lung cancer patients, they are never a smoker, right? So I personally have seen a 29-year-old lady presented with a breast lump and ulcerated. We thought it's actually breast cancer. And having a left humerus pain and evidence of metastasis to the humerus, left humerus, we thought it's a metastasis. After we had done a biopsy from the breast, it turned out to be primary of the cancer origin is actually from the lung. So from the lung to the breast, we write up a very nice case report and presented. So to our surprise, even though the patient do not have any risk factor, never a smoker, but it could be a passive smoking that contribute to that. And it could be genetic related as well, right? And we don't know what she has been actually exposed to, certain chemical, whatever, we're not sure. So we have seen 29-year-old, right? As young as 29 to have lung cancer. But based on this history, it doesn't point to a lung cancer unless X-ray show otherwise, a big mass or whatever it is, right? But again, TB, I always tell my colleagues and my medical officer during previous practice in GH, TB always a great mimicry, right? They mimic anything. They can mimic pneumonia. They can mimic what they call the lung abscesses. They can mimic tumors, right? We thought it's cancer, but end up it's just a TB, right? And it may mimic like metastasis, but end up with a miliary TB, for instance, right? So again, not only X-ray. In this case, you may want to do a sputum, what they call the AB direct smear and MTB culture if the clinical suspicious of TB is highly likely in these patients, all right? And you may want to do a mental test, ESR, or even a full blood count if you're suspecting some form of infection, especially for TB. You want to do full blood count, and usually in full blood count, what you'll find in differential, those white cell differential will give you some clue. They are not pathognomonic, they are not confirmatory, but sometimes based on that to give some judgment on the correct clinical ground, I can give some form of a provisional diagnosis. So TB, you will be usually associated with monocytosis, right? Bacterial infection, neutrophilia. But in the early stage could be neutrophilia and TB, and then later on be monocytosis. Though it's very high eosinophil, we may be dealing with some form of allergic bronchitis, eosinophilic bronchitis, for example, all right? And if the clinical assessment point towards just post-nasal dripping, you may want to consider paranasal sinus X-ray to begin with, if there is some form of evidence of the upper airway, what they call the cough syndrome example, right? Example, tender sinuses or enlarged turbinate that I mentioned to you before. If you suspect asthma, you may want to order spirometry or serial peak flow recording, right? Sometimes we can actually use a serial peak flow recording to look at the percentage or diurnal variation that can actually suggest asthma, because those methacholine challenge tests, those provocation tests are not easily available and are not 100% specific and sensitive as well. And it is not without risk. Only a certain center, big center, tertiary center will have this test, right? So many times we're based on clinical, the spirometry, reversibility testing, and serial peak flow to make a diagnosis of asthma, all right? So, okay, move on. If initial assessment investigation doesn't reveal any cause and is still persistent in terms of cough, or even with the good trial of the treatment for the initial common causes, for example, not applying to this case, but you're talking about chronic cough due to those common causes, sometimes without any other investigation, you want to give a trial of treatment. After 2 to 4 weeks, then you reassess this patient again. But if in example, if the response are not good and persistent, or there may be a new symptom or sign to suggest otherwise, so these are subsequent investigation of relevant if the cause remain not found, such as CT, right? You're looking to exclude significant lung disease, right? In patient with persistent refractory cough, even with a normal X-ray. So to share with you, many times when you look at X-ray, appear normal, but the patient have coughing, a bit of phlegm and all that. When you do a CT for further investigation, and that patient may have some form of GGO, ground glass opacity, or some minor, very minute patches of consolidation in multi-segment of the lung. That actually indicates some form of interstitial lung disease, like those non-specific interstitial pneumonia, which may not be readily picked up by our chest X-ray, right? Because it all depends on the resolution and the technical aspect of it when you take the X-ray, right? So secondly, you consider sinus X-ray, sinus CT and refer to ENT. If patient still have persistent upper airway syndrome, right? The symptoms. You may consider bronchoscopy if you're thinking of foreign body or history of suggestive of malignancy or endobronchial diseases, right? And you may consider 24-hour ambulatory esophageal pH monitoring if the symptoms are relevant. Patient of GERD, heartburns, and always precipitate the cough, right? So if the setting, clinical setting is appropriate, you may want to consider this investigation. So these are examples of possible investigation you may consider to delineate or to find out the exact cause to contribute to the chronic cough. But remember, chronic cough can be due to multiple causes, which I highlighted. 27% of the cases can be due to more than one in combination. So let's say you were to treat the asthma, but the cough is still persistent. You have done a treatment, good treatment for asthma with what they call the Symbicort, for example, both bronchodilator and steroid. Given them enough dose, you elevate the symptoms, but you actually get rid of all the triggers and all that compliance, the technique of inhaler, all are correct, but it's still having the troublesome cough, right? So then when you ask a patient further or invest further, you may find out patient may concomitant GERD, which you're not treating. Or maybe a patient with concomitant allergic rhinitis, which is not addressed initially. So when you address and treat them, then the asthma get control and the no symptom get control or the GERD get control, then the patient cough will resolve after some weeks of treatment, right? I've seen three together, allergic rhinitis with asthma. We always say one airway disease, right? When allergic rhinitis and the patient with asthma, you may have potentially allergic rhinitis in the setting of atopy, all right? So patient may have both together. And at the same time, obese patients or may have hiatus hernia with reflux. And this reflux always precipitate the asthma exacerbation and worsening of the symptom. If you don't treat the GERD, the asthma will not get control. If you don't treat the allergic rhinitis appropriately, adequately, the asthma may not get well controlled despite whatever medicine they are giving to them. So therefore, the take-home message is got to find out the cause and treat them adequately. All right. Okay, back to you, Kang.
Okay, so these are the investigation findings that I've done. So the HB is quite normal within 13.7. And total white cell was quite normal as well, 7.9. And the platelets were normal. So MCV, MCH, MCC was all normal range. So we did the ESR, and it was quite elevated, 103. So with a high ESR, young patient, hemoptysis, maybe most likely it could be a TB. So the X-ray, unfortunately, I was unable to take the photo. It was reported as there's some bronchopneumonia with some suspicious left hilar lymph nodes, possible TB. The patient was not really keen for mental test because it's time consuming. They wait for 72 hours. So after the X-ray, he wanted to go back and wait first. But the sputum collection was done the next following 3 days, and all 3 samples came back for acid fast bacilli. So this is actually a clear-cut case of TB. So I started the patient with treatment of TB with Accurate, which is a fixed combination pill. So there are 4 drugs in there. So notified to MOH and we counsel on compliance and direct observation therapy, and explain to the patient on the side effects and to come back immediately if the side effects are present and refer I for assessment. So this was what I initially thought. So you treat the patient with TB after diagnosis and everything should be fine. So 3 weeks later, even though the patient was better, I traced back the acid fast bacilli culture results, and it comes back as a Mycobacterium tuberculosis complex. And on the sensitivity finding, is only sensitive to streptomycin, which I did not give the patient. The ethambutol, isoniazid, and rifampicin were all reported as resistant. So other tests such as HIV was negative. He's not diabetic. The patient claims the symptoms mildly improved after 2 weeks. So the cough better a bit, no more fever, but the weight is still same, 44 kilos, and there were no side effects for this. So what should we do now when we see this? This is multi-drug resistant TB. So I would like to ask the audience again for a polling, what would you want to do when you encounter a patient with this kind of results? So I'll give you all 30 seconds to vote. So whether it's a wrong result and repeat again, or you want to stop all this and change to streptomycin, you want to ignore the results, just continue since the patient is improving, or you want to call for help and refer to someone who is expert in this. So the votes are still coming in. 60% have voted. Okay, I'll give 5 more seconds. Okay, so I shall end the poll. Okay, so let me share the results. Okay, so most of you want to stop the ethambutol, isoniazid, and rifampicin and change to streptomycin. Okay, so instead of using 4 drugs, just want to use 1 drug, a single therapy for a TB patient, which is not really that great. And streptomycin is usually injectable, so you have to jab the patient, and it's quite painful. After that, 28% wants to call for help, refer to someone else. Followed by that, some just want to ignore the results because the patient is mildly improving, and something is a wrong result. I want to repeat again. So what did I do was this is an Mdr Tb, so I'll just refer to a primary physician. So Prof. Ng, what would you do for a multi-drug TB?
Yeah, just some thought on the answers put up by the crowds, right? Wrong result, repeat again by the sum taker. And what worried me the most is the number 2, stop ethambutol, isoniazid, rifampicin, and change to a single agent streptomycin. And by and large, most of you, 50%, almost 50% of you actually chose this. And this will worry me most. And by the time, let's say, start treatment and a single agent refer to me, we may create what they call extensive TB resistance and all that, right? So therefore, and I'm glad those number 4 help. So you're asking for help. Even I myself, I will ask for help, right? So when you deal with the resistant TB, because I want to highlight that why it is important. The strategy for treatment has to be right from very beginning, right? I'll mention that in a while, okay? Right, let's move on. So no doubt, very clearly stating that from the history point of view, this patient actually has pulmonary tuberculosis, right? In the right setting of clinical information, epidemiology, and more so the patient actually got microbiology evidence of acid-fast bacilli in the sputum. But again, mind you, AFB direct smear is not enough to confirm TB, and the gold standard being a culture, all right? Because acid-fast bacilli can be present in other bacteria. Example, non-tuberculous mycobacterium, even in nocardiosis. So I always mention to my peers, 3 important causes for AFB positive in the smear. It would be what they call the MTB, Mycobacterium tuberculosis. It could be NTM, non-tuberculous mycobacterium, or it could be nocardiosis. So previously we have seen so-called chronic cough, everything will be the same, right? Chronic cough, with a bit of sputum, fever, weight loss. A HIV patient came to us, referred to work out for TB. Then end up this patient actually having nocardiosis, but it's not TB. But the sputum is being AFB positive, culture is being negative. What brought our attention to think of nocardiosis would be a lot of nodule in the lung with cavitations. not the classical presentation of X-ray changes in TB, right? I'm going to show you in a while the X-ray for illustrations, right? So, okay, back to this. Before I discuss or present on how we approach the treatment for MDR, a bit of definitions, all right, of TB resistance. So now this patient actually have what they call the resistant to isoniazid and rifampicin. So we define it as multi-drug resistance. There are other forms of drug resistance. Example, mono-resistant. They are resistant only one of the 5 first-line drug example. Would be isoniazid mono-resistant, right? Rifampicin mono-resistant. Mind you, when you have a rifampicin mono-resistant, usually they tend to be what they call the MDR. And sometimes with this expert molecular test, PCR testing, when you found a rifampicin resistant, they are surrogate for MDR TB, right? Okay, and we are polyresistant when they're resistant to 2 or more of the first-line drug, not both isoniazid and rifampicin. It could be isoniazid plus streptomycin, isoniazid plus pyrazinamide, and all that, right? And a primary reason for pyrazinamide and etambutol are not so common, right? So this case clearly indicate a multi-drug resistance. They're extensive or even totally drug resistance, right? So next, it depends on the number of drugs, right? And what are the contributing factors for MDR? Take-home message for all the clinician practice out there, this is very important, right? And for management of TB, or more so for resistant TB, it got to be managed by a physician who are experienced in managing. If not, we'll be creating more trouble, more resistance, and more MDR, more XDR, more totally resistant TB, right? And the major contributing factors for MDR is being non-compliance, again, non-compliance, again, non-compliance. And we always, share the important thought to the public and not to our peers is that MDR is actually a man-made disease to some extent, right? So remember, proper direct observed therapy dots is important, right? And those immunocompromised patients may be a risk factors, right, for Mdr TB. And those from hotspot area, from prisons, homelessness, or previously treated or relapsed cases, they may be Mdr TB as well, right? And recently, I saw a patient I treated about 4 years ago, isoniazid mono-resistant. Then I refer. So in Sungai Long Center, I treat TB, but I do not treat resistant TB because they pose a lot of risk to our staff as well. I do just treat a normal TB without any resistance. And I saw this lady about 4 or 5 years ago, culture come back with mono-resistance. And take-home message is that clinically and radiology, you can't really differentiate them much at the outset when you deal with someone with TB, right? It could be TB without resistance, or could be TB with multiple drug resistance. They appear the same in terms of history, examinations, and the radiology findings, right? And then she came to me about 4 years later, recently last month, came to me again with a little bit of cough, no weight loss, no fever, nothing, right? And I did an X-ray because of chronic cough for months, intermittent, right? Given antibiotic by GP, right? Even given some inhaled steroid because of thinking of post-infectious cause, because of heightened cough reflex with post-inflammatory effects. People give inhaled steroid as one of the treatment for post-infectious cough. And now it's not resolving, right? So then I did an X-ray. To my surprise, the so-called the O area of left upper zone fibrotic scar, it has multiple, what they call the patchy opacity. Not so much of cavitation, but very significant patchy of opacity, right? I mean, a little bit of cavitation, very mild, very subtle, and very fluffy. One of my professors in radiology in UIA last time would tell me, when you have a cavity with surrounding consolidation, very fluffy, like kind of appearance, usually quite indicative of the what they call the TB. When you talk about CT scan, I always look for tree and buds appearance. but it's not better than monitoring for TB, but in the good clinical information plus exposure with that finding is TB until proven otherwise. Because sometimes, no matter what you do, you can't culture them. So the diagnosis of TB with empirical treatment will begin with your clinical judgment and high suspicion of TB, right? Looking at the clinical information, your radiology, we make a decision, start anti-TB treatment, right? That saves life, especially you're dealing with those life-threatening conditions, okay? Right, so that patient I refer to IPR, right? Because I worry about the what I call the relapse, reinfections, right? Reinfection, after 2 years, we call reinfections, and or the same site with the existed isoniazid resistant, and given the what they call the other first line treatment that can actually induce a spontaneous what they call the resistance over time, it lead to MDR. That's my worry. So I refer for investigation, because in IPR they can actually do this gene expert molecular testing to decide whether this patient has rifampicin resistant. Then we are dealing with MDR, right? Some test kit, some what they call the molecular test can actually test the nucleic acid amplification test. We can actually test isoniazid and rifampicin together. That will help us to judge, are we dealing with MDR? We need to start treatment immediately, right? For infection control, reduce transmission, and for increase the success of cure, for example, right? Move on. Right, so I'm not going to bore you with the detailed guideline on the treatment regimen, because you guys won't be treating Mdr Tb, but I will give you an overview of how we actually treat Mdr. And this is based on WHO guideline, the treatment regimen prior to 2016, right? The mainstay of Mdr Tb treatment is you need to have one injectable drugs like those aminoglycoside and the fluoroquinolones, and additional drug of remaining class. We group them into group 1, 2, 3, 4, 5, right? So the priority will be group 1, 2, and 3. Then later by 4 and 5 to make up the numbers of the total number of drugs. So you need 5 drugs, right, by principle or more in combination to treat Mdr Tb. If you know the resistance pattern accurately, definitely, you can give 4 based on WHO guideline. It's all depend on what guideline you're referring to, right? Because there's no so-called a large randomized controlled trial for all this treatment. Many times there are studies to look into the efficacy and the treatment response and outcome. So based on those meta-analysis of all these multiple studies that are carried out in all over the world, WHO or even American Thoracic Society, European Respiratory Society, all to come up with the guideline. So in TB treatment, it ever evolve. It's always evolved after a few years. Whenever there is the study published of newer agents or newer combinations, or newer strategy of in terms of the combination of drugs and so on and so forth, they will derive a new set of guideline, which I'm going to show you in a while. All right. So these are the example of WHO guideline. The duration is 18 to 24 months. This is based on 2016 and prior. Next one. So these are the standardized regimens based on the pattern of the MDR. The what they call the alphabet is referring to the drugs. H is isoniazid, R is rifampicin. So these are the example of the drugs, standardized regimen based on the pattern of the resistance. Okay. Can you imagine the recommendation injectable? Will be being injected for streptomycin, amikacin every day, at least 5 times a week, minimum 6 months, or at least 4 months after first meal or culture become negative. Every day. Sometimes I pity the patient, they're already so thin and cachexic, left bone and skin, how to inject them, So they really cry. So therefore, we evolve. Okay, move on to the next one. Therefore, based on the current evidence and regimen change and evolve based on the WHO 2018-19 guidelines, we have these longer individualized regimens, we have a shorter standardized regimens, and they are standard set of the selection criteria for both regimens, right? So for those who are suitable for longer individualized regimen, for example, those patients who are not keen for injectable. You see, many times, can you imagine, we inject them every day, they got pain. a lot of psychology and emotional impact there. So they may tend to default. Once they default, will create more trouble, all right? So therefore, one of the reasons for this regimen is those patients who are not keen for injectable, right? Or those patients with those immunocompromised patients, those with meningitis and all that, those group of patients will be suitable for this longer individualized regimens. So all using oral regimens, and there is incorporate the newer agent like the betaquilin. Clofazimine is not a newer one. Betaquilins, and also the what they call the there's one name called delamanate, right? And these two agents actually have shown a higher culture conversion rate in the studies. So therefore, it was incorporated in the regimens, right? At least 4 drugs based on WHO guideline, but ATS recommend 5 drugs, right? And the total duration of at least 18 months. For the shorter standardized regimens, it's actually based on the existing old classification of group of drugs without including bedaquiline and also the delalamate. So the intensive phase will include 4 months of 7 drugs. Can you imagine? Oral plus injectables, right? So basically, patient will be, on 7 drugs, including injectable, followed by 5 months. So we can shorten the duration from so-called 18 to 24 months for the old regimen to 9 to 12 months. But can you imagine the patient have to swallow so many tablets, all right? So again, these are based on the available evidence to show its efficacy that lead to these recommendations, all right? Okay. Okay, other important aspect in TB management, not only in TB, but for Mdr Tb, for all the TB in management, in order to have a success in terms of the treatment success, reduce the transmissions, to improve mortality. These are important aspects. Contact tracing, dots, right, which have shown to increase success, reduce burden of the disease. In HIV patients, it prolongs the survival. Refer to the center which specialize in treating drug resistance. Do not ever treat drug resistant TB ourselves unless you are experienced in dealing with them, right? Definitely, there are standard guidelines, when you have resistant isoniazid, what is the regimen, how long you need to give based on current evidence, we can follow, right? Usually we will follow the guideline. But the decision of the selection of drug, many times will based on, the resistant pattern, the compliance issue, whether patient has what they call in terms of the cost, right? The availability of the drug in the center. So there are multiple factors that will help us to decide what will be the best combination out of those drugs, okay? An appropriate and adequate treatment regimen is utmost and paramount important. Never ever make a mistake from the beginning. When you make a mistake, sometimes we do see patient was treated in district hospital for resistance with underdosage, inadequate regimens. Instead of 5, giving 4. Then when you refer to us, we are so worried about XDR, all right? So they will give us a nightmare, all right? And not forgetting isolation are important, right? When you deal with the resistance. Therefore, this patient will refer to IPR. Many times with those Mdr Tb, we refer to a center with a proper isolation. We need to isolate them and give them treatment, assure they are taking the drug every day until sputum conversion. We do monthly sputum smear and culture until sputum conversion for 2 or 3 times. Only then we'll let the patient go home, right? So it is a prolonged process, and it's quite taxing for both patients and also for the healthcare workers as well, right? And not forgetting to take care of the environment to reduce the risk of transmission. Okay? When you have a chance to go to IPR, they're all open air kind of a concept ward, right? When the air flow from one end, it will go to the other end with all the window open at the side, right? So the airflow, the air change per hour are adequate to reduce the amount of the bacilli in the environment and to reduce the risk of transmission. Just like old-fashioned general hospital, like in Kuantan is one of them, Terengganu. When you visit all this hospital, both ends is all open. the door and the window, one end blow, another end will go out. That's why we hardly see from my practice in Kuantan GH, we have isolation ward. We convert one ward at the end into a respiratory ward. And we have isolation ward just for TB. And the rest will be for respiratory non-infectious diseases or just pneumonia, not TB. So the airflow, so we don't see so much of cross what they call the infections, from one patient to another patient, for example, in the ward itself, right? All this proven to be effective, adequate ventilations, right? In our TB clinic, we have installed the HEPA filters, and in IPL, you can see ultraviolet lights have been installed in their clinics, right? That all these are a measure to reduce the what they call the load of the bacteria appear in the environment that pose the risk of transmission to the staff and the patients. All right. Okay. I think there are a few more slides. So treatment outcome for Mdr Tb. You see, these are the study which I compiled with Mdr Tb treatment with the second line drugs. There are treatment success. There are treatment failure as well, leading to death. And certain proportion of patients will require surgery. Right. Next one. So these are the indication for surgery for some Mdr Tb patient who has persistently positive sputum culture beyond 6 months. Present of complication, sometimes the patient has massive hemoptysis. We have seen TB die of massive hemoptysis in an ICU, but you can't do anything because the patient are not stable to move to the what they call the OT to do a resection, lobectomy or ligation or whatever it is. You want to ask the interventionist to do the embolization, arterial embolization, stop. It's unstable hemodynamic to transfer the patient to the radiology department for CT-guided intervention. Can't do. And we just give conservative treatment, and unfortunately, patient die because of massive hemoptysis leading to asphyxia, all right? And those with bronchopleural fistula, all this will require some form of surgery in order to sort them out. And those intolerant to anti-TB treatment, no matter what, how many regimen you try, whatever, just can't tolerate, we have seen, but not common. So that may be indication for surgery. And bacteriologic cure rate is more than 90% if you combine drugs plus a surgery, right? It's based on the literature. Okay, next. So I think that's about it, yeah, okay.
So in the end, the patient was referred to IPR for further management. So from IPR, they said that the patient wants to go back to Indonesia because he came in on a social visa. So the treatment will be very expensive in Malaysia since he's a foreigner, and the treatment is very expensive, but it's a very long-term period. So, and when I thought this was the end of this case, so after 2 weeks later, the employer informed me that the patient is already back in Indonesia, and he went and see his doctor. That I wrote a letter, and he was there. But the AFB sputum there was negative despite multiple repetition. So the doctor there is querying whether we are treating him properly since the AFB is negative and X-ray was relative normal. So he requested for copies of his test, so which I gave him, and now he's on treatment, of course lah. So before I end my case, there's just one question that's lingering in my mind. Can Mdr Tb still respond to first-line TB drugs even though the CNS shows resistance? Just like this patient, he was AFB sputum positive, treated him, the culture came back as multi-drug resistant. However, when he's back in Indonesia, all the tests are negative for AFB sputum. So before I end the case, just summary from my view, TB is prevalent in Malaysia, and all patients with chronic cough should be screened for TB if indicated. But you need to rule out other chronic causes like GERD, post-nasal drip, environmental causes, etc. And then when you treat a patient with TB, always review the TB sputum culture results. Although it will take 3 to 4 weeks, but always remember to trace it. You might just find a multi-drug resistant TB, or maybe a patient whom the culture comes back as negative. Okay, so Prof. Ng, any last words from you? Prof. Ng?
I mute my mic, sorry, Kang. Yeah, so I think Dr. Kang had put up a very pertinent, important point that illustrate the culture result, right? So are we dealing with a false positive result, which can happen in the lab? So many a time, if we were to deal with the false positive result, it could be due to either because of cross or because of the contaminations, all right, or because of the lab error. Okay, so therefore, it is actually very important that we need to actually reduce those errors. Otherwise, the decision making for treatment will be wrong. All right, and okay, I think later on, Prof. Niao will actually highlight on those smear effects and also additional molecular testing, which will have of relevant when we deal with the Mdr Tb as well. Let's listen to her later on, right? Okay, now a couple of slides left to sum up the learning point in terms of respiratory physician perspective, all right? We do see a lot of chronic cough patients. At times, we really scratch our head, what is going on, all right? So the first learning point is patient with chronic cough should not be treated symptomatically. And I've seen a patient with TB walking around, and someone is a truck seller, you know, selling foods and drinks, and is in touring around here and there to sell his food, and been seeing GP for a few times, even seeing a Chinese practitioner for some treatment. No doubt some treatment will have some improvement in terms of symptoms. Do you all know that our normal antibiotic also have an activity towards the TB? Example, your Unacin, your Augmentin, right? An expensive one to be linezolid is one of the options for second-line drug TB treatment. Even your quinolones, I'm very worried when the GP like to use a lot of generic quinolones, especially the fluoroquinolones, levofloxacin, moxifloxacin. They're so easy available, and they start out treatment, end up it's actually a TB, but they treat it as normal bacterial infection. We immediately induce fluoroquinolone resistance, right? They can contribute to actually XDR later on, right? And so remember the take-home message for some principle of treatment. When we see a patient with pneumonia, we're not sure whether it's TB or not, we try to avoid the drug that have activity towards tuberculosis, right? So we don't induce any resistance, okay? So we try to find the cause. If clinical assessment suggests more serious illnesses, just like in this case, fever, weight loss, and all that, we need an X-ray. Don't just treat symptomatic, all right? So regarding the patient I told you 1 year, come to me, already got cough. When the patient come to me because they got hemoptysis and short of breath, coughing may not brought the patient to see you because they thought it's just a smoker, lung cough, whatever it is. But come to me, do an X-ray, the whole lung is actually full of whitey patches. It's a severe TB. A smear is plus, 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 all right? Okay, next learning point. Okay, I'm going to show you some X-ray, right? A patient presented with chronic cough, sometimes a bit of strict hemoptysis. Does it look normal? One look at it, you may miss something, right? But you look a bit closer, you can see something at the right left hilar region. Some people may mistake it as your what they call the bronchus, right? Or the vasculature. But in actual fact, there is a mass with some surrounding very odd kind of consolidations, all right? So in actually, we've done a bronchoscopy because patient present with chronic cough and all. These are real cases. So we've done a bronchoscopy for this patient. Before that, we've done a CT. It showed there's some hilar masses with lymph node, mediastinal lymph node. It's actually cancer until proven otherwise, all right? So therefore, we've done a bronchoscopy and turned out to be this patient actually have small cell lung cancer, right? Okay, move on. Okay, this patient middle age, a smoker, present with recurrent cough, intermittent fever, and sputum productions. Seen GP multiple times, given multiple course of antibiotic, you named it, all right? So then refer to chair physician because of unresolved pneumonia, and the persistent patch is still there after 2 or 3 months of treatment, and patient get fed up, nothing get improved, and still have troublesome cough, and came to see us. We do an X-ray, and many times GP may have done an X-ray, right? If no, we've done an X-ray and it's reviewed, there's a consolidation at the right middle, right lower zone as such. There's no effusions there, all right? There's no hilar, seems to be quite okay, right? Then we proceeded with a CT for these patients, and it shows some lesion in the bronchus, all right? And we proceeded with a bronchoscopy. Next slide. And we found that is a nodular lesions causing subtotal occlusion of the middle loop bronchus. And biopsy showed this patient actually got lung cancer, right? So the take-home message is, next slide, is somebody have recurrent pneumonia or unresolved consolidation, think of endobronchial obstruction. It could be due to benign adenoma, benign lesions, or even post-TB bronchial stenosis due to scarring, right? So it could be due to very benign lesions, or it could be due to malignancy, or simply because of a previous aspiration of the foreign body. Then it lead to inadequate clearance of the sputum at the particular lobes that lead to infection again and again. It may be given antibiotic, partially treated, improve symptom, but doesn't go away. So think of endobronchial obstruction, right? For those with recurrent pneumonia and unresolved consolidation. Move on. And another learning point is X-ray may be subtle and normal, especially in interstitial lung disease, which I've illustrated to you. When you do a CT for those patients in the clinical setting of very suspicious interstitial lung disease, like never a smoker, reduced effort tolerance, lung may be mild, clarifying, Velcro-like crepitation, X-ray, hardly anything. Then we're quite suspicious of some form of interstitial lung disease. We did a CT, then it illustrates it's the interstitial lung disease. So it may be very subtle in X-ray. X-ray normal doesn't exclude pathological lung disease. Sometimes you may not see because of cardiac shadow may obscuring, or very central in nature where your airway, your esophagus shadow is obscuring them. We have seen a huge tumor is behind the heart shadows, but we can see some outline looking at it. Then we suspect, some mass is growing behind, the heart shadow. Then CT scan, bingo, there's a tumor there, right? Even bronchiectasis, because you see in the lung, in the X-ray, you see a lot of airway, right? So it may not actually obviously pick it up, okay? So when you do a CT, you may actually pick up more readily, right? Could be a contributions for chronic intermittent cough, right? So next one, and this is the important points to take home. Suspect TB if these are the pointers. Chronic cough with risk factors, HIV with unexplained cough and fever, unexplained illness, including symptom for more than 2 weeks with risk factor of TB, those pneumonia never resolve after 7 or treatment with TB risk factors, right? Or incidental finding on X-ray suggests of TB with risk factors, right? Even in the absence of symptom. Next one, suspect resistant TB if you're having a persistent or progressive clinical and or radiological finding while on TB treatment. Lack of conversion of culture to negative during first 3 months of anti-TB treatment, right? I mean, after you start treatment for normal TB, so-called normal TB, anti-TB treatment, the first line drug, and the culture remain positive at 4 months. Think of resistant TB. And those patients with incomplete adherence always default. Take today, forgot tomorrow, right? Not properly, what they call the adhere to, or those simply exposed to the patient or the family member with resistant TB before, or those from a high prevalence area of resistant TB. So think of drug-resistant TB, because there's a thing called empirical treatment, right? If in the right clinical setting, we suspect strongly drug-resistant, we may not give the routine 4 drugs. We may give 5 or even 6 drugs, usually 5 drugs with the injectable drugs on board. And then usually add 2 more on top of the first line, so that if let's say the patient have 2 resistant, we still have 4 remaining to counteract the spontaneous mutations, example, that lead to the resistance. One interesting fact, actually, I want to show you the slide. There is a thing called naturally occurring spontaneous mutation, result in drug resistance, right? In a very predictable rate. Example, rifampicin, 1 in 10,000 8 organisms were resistant, right? So in one study, it mentioned that if for isoniazid alone, 100 organisms, based on this principle, 100 organisms resistant on day 1 itself, right? So therefore, you can't be treating the patient in single drug like streptomycin as what been put up just now in the quiz. You're definitely going to develop resistance very fast for streptomycin. So a principle is never add a single drug to a failing regimen, right? You're going to create more resistance as such. Okay, move on. and some X-ray before I end the session. So these are classical pulmonary TB changes. So in the left one, right upper loop, a consolidation with cavity, right, with the well demarcation of the fissure, right? And then this mild in nature. We have moderate in nature. Can you see the right upper and middle zone consolidation with a lot of small, tiny cavitation, right? A cavity can harbor up to 1 in 10,000, 10 in 1,000 of 6 organisms, a lot of millions there, you know, right? Can you imagine a patient with smear positive with cavity? They're very infectious. You should be scary of them, right? Okay, next one. It could be bilateral, severe in nature, both ends, you can see a lot of cavitation, or it can be miliary in nature, very millet-like kind of a nodule, very small, couple of mm, and because of hematogenous spread, it spread all over, right? And one important teaching point I always teach the doctor is that when you see a nodule, small nodule of uniform size, think of TB and infective in nature. As opposed to those malignancy metastases, like cannonball appearance, the size of the nodule will vary because of different time metastases and the growth or the tumor of the particular nodule. So you can see different sizes of various segments of the lung that indicate metastasis, right? Okay, move on, next one. Last but not least, drug-resistant TB treatment. In order to have a good patient outcome, you need to have rapid, accurate diagnosis, proper treatment, adequate regimens, close monitor, assure compliance to get the success with the good patient outcome. With that, I thank you for your attention.
Okay, thank you so much, Prof. Ng, for the explanation of TB. So I'd like to move on to Prof. Miao, who explained to us the basic sciences of MTD. So, okay, let me off this first. Okay, Prof. Miao, move on to you.
Yes, thank you, Dr. Kang. Can everyone hear me?
Yes, Prof.
Okay. Yeah, after such a long discussion, a very interesting, detailed discussion from Prof. Ng, I think I can shorten my presentation a bit. I'm sorry I didn't sort of look at his presentation before I prepared mine. So there's a little bit of an overlap, but I'm just going to focus more on the lab science rather than the basic science of TB management. Okay, so I try to share my slide. I hope it comes on. Can you see the slide? Oh.
Yes, Prof. Yes.
You've got to respond, otherwise I don't know whether you can hear me. Because I had a problem with the mic earlier on. Okay, so let me just
Prof, we can't hear you, Prof.
You can hear me?
No, it's better. It's better now. Yeah.
Okay, so it's a case of Mdr Tb that's confirmed by smear microscopy, culture, as well as drug susceptibility testing, DST. And this patient was treated with Accurate for 4 weeks, which the treatment seemed to have improved his symptoms a little bit, but his sputum AFB microscopy became negative, and this is unexpected. And so Dr. Kang asked me to try and explain whether the Mdr Tb can respond to Accurate for therapy, because this is a therapy for first line for drug susceptible TB. And if the Accurate 4 therapy is not effective on Mdr Tb, then why did the patient's sputum AFB smear become negative after starting treatment? Okay. Okay, can you see slide number 2?
Yes, Prof. Yes.
Okay. So before we answer those 2 questions, let's have a quick revision on the DST of tuberculosis. So Prof. Ng has said so much about the treatment and the features of different types of drug-resistant TB. So I think I can just go on to just one little extra category that I put into his list of different types of drug-resistant TB, and that is pre-XDR TB. So we have DSTB, referring to TB that is susceptible to the first-line anti-TB drugs. And then we have mono-resistant TB, which Prof. already referred to. And these are the TBs that are resistant to either rifampicin alone or isoniazid alone. And the Mdr TBs, of course, the multi-drug resistant TBs that are resistant to both rifampicin and INH. By definition, of course, they can be resistant to other anti-TB drugs as well. But by definition, when we say Mdr TB, we are referring to rifampicin and isoniazid resistance. And then we have the pre-XDR TB. XDR TB is, of course, extensively resistant TB that's resistant to practically all the anti-TB drugs we have at the moment. But there is a stage before that WHO just recently included, and that is pre-XDR TB, referring to Mdr TB or rifampicin-resistant TB that is resistant to just one fluoroquine alone. So they haven't advanced to the XDR TB stage yet, but they're moving towards XDR TB. So you can see the whole spectrum of drug-resistant TBs, starting from the drug-sensitive TBs to mono-resistant TBs, to multiple drug-resistant TBs, to pre-XDR resistant, pre-XDR TBs, and to the extensively drug-resistant TBs. Okay, so let's look a little bit on the laboratory diagnostic facilities we have here. Just now, Prof. Was saying that many times the clinicians have to start empirical therapy first before they get the drug sensitivity test results back. But I think this is, not something that we should encourage because of the rapid emergence of resistance if the doctor has not chosen the appropriate anti-TB drugs to start with. And also nowadays, we are not like in the old days when we had to wait 8 weeks, 10 weeks to get our results back because we're using agar-based culture methods. Nowadays, we have liquid culture systems that shorten the incubation time from 8 weeks to 2 weeks only. And sometimes when there are lots of bacteria in the patient's sputum, we can even get the culture result back after 4 to 5 days within the same week. So there's no good reason to actually start therapy before DST. All we need to do is improve our laboratory diagnostic facilities so that the laboratory can provide rapid, accurate results, DST results to the clinicians treating the patients. So the culture-based DST in Malaysia, most of our Malaysian hospitals use the Bactec Midget 960 system. You can see the machine. Can you see my arrow? Yeah, this is the Bactec Midget machine. It's just a big incubator with lots of drawers. And in each drawer, there are lots of racks into which we can put these tubes. And so the patient's sputum sample is collected, is put inside these tubes to be inserted into the racks and incubated in the incubator. Then after about 1 to 2 weeks, usually, when we get a positive signal from the machine, the positive tube is then taken out, and oh dear, sorry, how do I get back? Okay, so the positive tubes are taken out, and put from the positive culture tube, the contents of the tube will be transferred to a series of fresh tubes, each one containing a different antibiotic. So for first-line therapy, sorry, my fingers are not working well. Okay, to look for Mdr Tb, we will put in the first-line drugs, which is streptomycin, isoniazid, rifampicin, and ethambutol, SRE, into each drug into one of the tubes, and then we would incubate the tubes with the organism back in the incubator. And within another 1 to 2 weeks or so, we should be able to get the DST results out, right? Okay. Next one. Okay, so the other type of lab testing that we have in the lab are the molecular tests, the molecular DSTs. These are tests to look for bacterial DNA that contain genes that are associated with the drug resistances. So there are very rapid DSTs, molecular DSTs, and they are also standard molecular tests that we do in the laboratories. The rapid tests have this advantage of providing results within as short as 2 hours, right? So again, this is one reason why we do not need to start off patients off with empirical therapy first. We can wait for the rapid test results, provided this service is, of course, available in the hospital you work in. So with the rapid DSTs, the most widely used machine is the Gene Expert, also referred to by Prof. Ng just now. And you can see here, okay, just follow my arrow. This is a little desktop machine with about 4 drawers that you and the patient.
Prof.
Turn on. Yeah, sorry.
You
can't hear me again?
Yeah, a bit just now. Yeah.
I have to keep my mouth practically right next to the mic for you to hear me. Sorry. So in this machine is actually a real-time PCR machine. So the DNA is extracted, right, in the machine itself from the TB bacilli in the patient's sputum, and then the DNA is amplified, and we diagnose the TB from the amplification product. We can also test for rifampicin at the same time. So the results will be TB detected and rifampicin sensitive or rifampicin resistant, right? So this is the most rapid method we can have to diagnose rifampicin resistant TB. But rifampicin resistant TB can be either monoresistant, as Prof. Ng has told you just now, or Mdr Tb. And most of the time we assume that when we get a rifampicin resistant result, that TB in the patient sample, other that TB bacillus in the patient sample will be an Mdr Tb, because rifampicin resistance 90% of the time is caused by the Mdr Tb. Having said this, we also have recent literature results from recent studies to show that in the past decade, the monoresistant, rifampicin resistant TB has increased in incidence, as well as mono isoniazid resistant TB. So now it's important to actually test for the isoniazid resistance as well. So this test is not given by the Gene Expert. Gene Expert only gives you rifampicin resistance result. But what is the advantage of doing this isoniazid resistant testing as well is because if you look at the patient treatment, I think I have to go on the next slide. Yeah. No, sorry. So this is because both rifampicin monoresistance and isoniazid monoresistance can give rise to more serious or more adverse patient outcomes than drug-susceptible TB. And so they need to treat, but you don't need, they need to be treated, but you don't need to go straight on to second-line anti-TB drug therapy. They can be treated with a combination of first-line anti-TB drugs. You just exclude rifampicin if the strain is rifampicin resistant, or if it is isoniazid resistant, you can just exclude isoniazid, but you can still use some other first-line drugs. But if we assume that every resistant rifampicin resistant strain is an Mdr Tb, then we are obliged to start the patient off on Mdr Tb therapy straight away. And so, but then this Mdr Tb therapy is long. It's accompanied with lots of toxicities. So we may be unnecessarily subjecting the patient to a toxic therapy when, in fact, this patient can be treated with first-line drugs, yeah, for a monoresistance. That is why I'm always promoting the test of rifampicin resistance as well. So we can get this simultaneous testing for rifampicin and isoniazid in this other molecular test that I've shown here on the right-hand side at the bottom of the slide. This one is called genotype Mdr assay. This is a line immunoassay that's available in the reference TB laboratory, as well as in university, as well as the private laboratories. Yeah, here it's also rapid test, but because we have to extract the bacterial DNA from the patient sample first, and then amplify it in a PCR reaction before we can use the amplified product for the DST. So this test takes a bit longer to give results, because PCR itself takes about 4 hours to be complete. And so, but still, the same day test results are available. So we don't really have to wait for days to get the results. Right? You can get the results back on the same day that you send your sample in for testing. And this test uses these strips that are impregnated with gene probes that will pick up the genes with mutations that are responsible for drug resistance in the Mycobacterium tuberculosis. Right. So these are two examples of molecular tests that we have at the moment in Malaysian hospitals. But despite all the advantages of these molecular tests, they cannot yet replace the culture-based DST. We will still need to have culture-based DST. Because number one, they are not the sensitivity of the molecular test. We would assume it to be better than the culture-based test, but actually it is not. The sensitivity of molecular tests is actually less than culture-based DST, right? And also, the molecular tests provide evidence of genotypic resistance, which means potential for resistance, not express resistance. Express resistance is phenotypic resistance, and you can only get that with a culture-based DST, because you're growing the organism in the presence of a drug. And if the organism can grow in the presence of drug, it is very evident that the drug has no effect on the organism, right? So we can actually see the resistance in front of our eyes. But when we do molecular tests, we're looking at genes, we're looking at resistance determinants and so on. We can't actually see the resistance, because the gene can be switched on and off. The gene responsible for resistance can be switched on and off. So when the gene is present, but it is switched off, you won't see any expression of resistance. Yeah, and so although some physicians are still afraid to use drugs with only genotypic resistance but no phenotypic resistance, because the gene can be switched on again when the organism is in the patient's body. But sometimes it takes some time, or we don't know how long it's going to take for the genotypic resistance to be expressed. So it gives us a period of time in which we may be able to use the drugs that do not have phenotypic resistance, even though they have a resistance, they have genotypic resistance. We can still use those drugs for a short period of time first, right? And that may sort of again affect our choice of therapy, depending on the patient's history and the patient's clinical characteristics. So yeah, so we go on to the next slide. Okay, so we come back to the patient's results now, discussion on the patient's results. The patient's DST results shows Mdr Tb, which is sensitive to streptomycin, resistant to RI and E, but pyrazinamide was not tested. So pyrazinamide resistance is not very high among first-time TB patients. It's only about 2 to 5% among TB patients, but very high at least 50% or more among the Mdr Tb patients, and also patients who have been treated, who have been previously treated with TB. So why don't we test pyrazinamide? This is often not tested in our laboratories here. 3 reasons. Number one is because pyrazinamide is not included in rapid molecular tests, right? Most of molecular tests, as you can see, only test for rifampicin or rifampicin and isoniazid sensitivity. And the second reason is pyrazinamide requires a culture medium with low pH, because this drug can only be active on TB bacilli in an environment with low pH. And so this low pH is usually not good for the growth of bacterium. So for culture-based tests, we would have to buy a special kit for pyrazinamide testing. The usual kit would come with SIRE, streptomycin, isoniazid, sambutal, and so on, with the pH of the growth medium around 6.8, 6.9 or so. And this is no good for pyrazinamide testing. So now we have to buy a special kit with growth medium with a pH around 5.9 for testing for pyrazinamide. And most laboratories, they don't bother to do this. Why? Because pyrazinamide sensitivity is not required for the diagnosis of Mdr Tb. So our prime purpose for doing DST right now is to see whether the patient has Mdr Tb or not, right? So since pyrazinamide is not in the definition of Mdr Tb, most laboratories think it's okay not to perform this test, because Mdr Tb is defined by resistance to rifampicin and isoniazid only, right? But I think this is also something that I am not in agreement with, because if we do not test pyrazinamide sensitivity, we are denying the patient of possible treatment with first-line drugs. So I've given you this cartoon here in the middle, if you can see. We have these first-line anti-TB drugs: streptomycin, isoniazid, rifampicin, ethambutol, and TB. Prof. has already told you the reasons. Emergence of resistance is very rapid. And also, it is an injectable drug. You can't give it orally because it's not absorbed in the GIT. And so nowadays, if we use streptomycin, we research for recurrent TB. So we're left with IREP for first-line treatment of TB. And if we have...
Prof, you're breaking up, Prof.
Breaking up again. Okay, sorry. Is that better? Hello? Is this better? Hello?
Yes, Prof. Yes.
Only one spot, and so that my voice doesn't break up. Okay, so with IREP, if we don't use streptomycin, right? So if we have
Prof, it's not that good. You don't agree again.
okay, let me try to
It's better.
I have to lift up my laptop. Okay, this is better, right? Okay, so just keep on letting me know if my voice falls off. So we are left with, if we have isoniazid resistance, the eye with a red background shows isoniazid resistance, we will be left with only three drugs.
Prof is very soft.
Oh dear.
Yeah, now this is better. This angle is better.
This angle is better. Okay, so we'll be left with REP for treatment, right? And if we do not test pyrazinamide, we'll be left with just RNE for treatment. And we cannot have 2 drugs in the intensive phase treatment. So that means we cannot use a first-line therapy at all if we do not test for pyrazinamide. Similarly, if we have rifampicin monoresistance out of IREP, again, if we knock out the rifampicin, we will only have IENP left. And if that should be okay, because we still have 3 drugs left to have this 3-drug therapy. But if we do not test for pyrazinamide, see, we will be knocking out pyrazinamide as well. Then we'll be left with just 2 drugs, I and E. So again, we will not be able to use first-line therapy at all for this patient, right? So there is a role for pyrazinamide testing in patient management. It gives us an extra drug to use to prevent to avoid giving all patients second line therapy when we get when they have or rather when it's possible to give them first drug therapy instead, right? And also in this case, I also noticed that the second line drugs sensitivities were not tested because the diagnosis Mdr Tb. Nowadays, we would like the lab to actually test the moment we get Mdr Tb out, the result out in our lab. We should go on to also look for XDR Tb, because you will need to know what drugs to treat the patient with. So what if the patient actually has XDR Tb, right? Because you haven't tested the second line drug, so you won't know whether this patient has XDR Tb or not. You've just done, drug testing to identify Mdr Tb. It's important to look for XDR Tb because this drug-resistant TB has spread to many countries. WHO has actually reported 123 countries out of the 195 countries in the world, which means 63% of the countries in the world, having at least one case of XDR Tb in the country. So, and also these countries include Indonesia, and this patient is from Indonesia, right? So I think Indonesia has reported at least 100 over XDR Tbs already among the population. So I think another thing that we should ask the laboratory to implement is to provide results for XDR Tb. And it is possible for the laboratories now because we have modern laboratories with modern facilities. We should be able to provide these results. It's just that the clinicians don't ask for it, and the laboratories will take it easy out. Yeah. Okay. So we go on to the last slide. Sorry, I've got to pick up my laptop and put it down again. Okay, so we come back to Dr. Kang's question. Can Mdr Tb respond to accurate IV therapy? And why did the sputum AFB become negative? If the accurate IV therapy, which is a therapy for drugs susceptible TB, if it doesn't work on Mdr Tb, then why did the patient's sputum become negative, convert from positive to negative? So again, we look at this cartoon here. It gives you the drugs in accurate IV. This is rifampicin, isoniazid, ethambutol, and pyrazinamide, 4 drugs. The patient's DSD results show that the TB bacillus is streptomycin sensitive, but we don't want to use streptomycin for therapy. So this leaves us with IREP, but the patient's isolate is IRE resistant. But what about P? Yeah, we don't know whether the isolate is resistant or sensitive to pyrazinamide. So if the TB bacillus in the patient is sensitive to pyrazinamide, then this could give a possible reason for why the sputum smear microscopy has become negative. Because although the pyrazinamide by itself cannot get rid of the Mdr Tb, yeah, it could have reduced the number of TB bacilli in the patient's sample to cause a false negative AFB microscopy result. So I think this is the most likely explanation for this negative sputum AFB microscopy result in the patient. Yeah. Okay, so the last slide just sums up the factors that affect sputum smear microscopy. We've said that there are possible false negative results. So what are the causes of these false negative results? Well, the first one, volume and quality of sputum sample. This is very, very important. Rubbish in, rubbish out. I'm quite sure you remember. So we must have enough good quality sputum coughed out from deep within the lungs and not obtained from the oral cavity. The microscope we use, of course, must be well maintained and aligned, and the microscopists must be trained and experienced. But it's well known that AFB microscopy has low sensitivity for the diagnosis of TB because we need at least 10,000 AFB per mil of sputum in order to get a positive result. And so you can, but we do have means to increase the sensitivity in the lab. We can use sedimentation of sputum. That means allowing the sputum to settle down to the bottom. But this requires overnight sedimentation, so it's going to slow down the reporting. But we can also use centrifugation, which we are not fond of because centrifugation is a biohazard to people working in the lab. We can also use filtration. And filtration, that means that we liquefy the sputum, get rid of the cells and the debris in the sputum, and then filter it, and then stain the filter membrane on which the AFB should be on. And so you can see the two pictures at the bottom. The one on your right shows you, an AFB positive unfiltered from an unfiltered sample. Can you see the AFB is a bit difficult because there's so much of dirt. There are a lot of mucus strands and cells, human cells, right? But after clarifying the sputum, after filtration, look at the picture on your left-hand side. Beautiful picture of AFB, right? Nothing to obscure the AFB in the concentrated smear. So it is possible to implement all these methods to increase the sensitivity of the AFB smear microscopy. And of course, the sensitivity of the smear microscopy goes down dramatically after starting therapy. Yeah. So the last thing I want to say is that for post-therapy follow-up of a patient, microscopy alone is not sufficient. You've seen that so many things can cause a false negative. So culture is necessary to test for to test a follow-up patient sputum samples. This culture will not only just detect viability, because it's quite difficult to tell dead bacteria from viable bacilli in a microscopy, but culture actually tests for growing cells. So we know when we get a positive culture that the TB bacillus in the patient sample is viable. So besides testing for viability, which is something that we want to know after starting therapy to see whether the TB in the patient sample is actually still alive, we can also look for anti-Ms like Prof has told you earlier on. And this co-infection by TB and anti-Ms, not that rare. In University Hospital, when I was working there, we regularly get about 20% of, and we get anti-Ms in about 20% of our positive TB cultures. So it's something that we need to keep in mind. So these anti-Ms will also be AFB. So when you do a microscopy, you will have a false positive AFB microscopy. Yeah, but culture is, with culture, we're able to differentiate the TB bacilli from the anti-Ms. These anti-Ms are usually resistant to first-line anti-TB drugs. So they can survive even after starting the patient on a therapy. And so if we see the positive AFB in a patient's sample, in the patient who has been started on therapy, we may think that this indicates a failed therapy. Yeah. So, but if we can culture the anti-Ms to explain the presence of the AFB on microscopy, then it could tell us that the patient has actually not failed therapy for TB, but is having an anti-M infection other than the TB infection he has. Okay, so I'm sorry I have to rush through all of this because I think it's long past your tea time. So I will end my presentation here. Thank you.
Thank you so much, Prof. Miao, for the explanation. So